Hello everybody, welcome. We are Isamizu and Dr. June.
Dr. Isabel.
So today we have a Dr. Jason Scoppa. Welcome, Dr. Jason.
Hey, thanks for having me.
Yes, thank you. Thank you for sharing your knowledge. So we want you to explain people exactly what is it that you do, what's your field of practice?
I'm certified in SOT, a chiropractic technique called sacro-occipital technique, which kind of takes bits and pieces of osteopathic medicine and chiropractic. It was developed by a guy who's a cranial osteopath and a chiropractor. And then I'm a certified craniopath through that group. I teach with them. And then I'm also certified in a technique called applied kinesiology, which kind of looks at what we call the triad of health, which is, the physical, the mental, and the chemical components of the person, and kind of keeping those in mind as you're working on somebody.
Wow, that's super interesting. Can you elaborate a little more? Because a lot of people won't know exactly what is it that you do that is different than when they go and have an adjustment, for example, with a chiropractor.
Sure. So a lot of what I'm working on is indicator based. So the body is kind of telling us where to go, when to adjust, when not to adjust, how to adjust. So it kind of takes it out of my hands. It's a little less subjective in that way. The cranial work specifically, we're working on the cranial bones themselves, but also on the sutural system, which is connected with the cranial dura. So it's the covering of the brain and spinal cord. And then that covering actually anchors into the sutures within the cranium. So you're affecting the nervous system through the sutures, and then through the cranium, and then through the bite, as you know, with the stomatognathic system. So you're really affecting the neurology. And then in SOT, we're really focused on the SI joint, which is on either side of the sacrum, down at the base of the spine. So proprioceptively, those joints and the jaw are really, really dense in what are called proprioceptors, which give us our spatial awareness and contribute to our balance. So if you can get neurologic stability in the jaw and the SI joint, and you get as much tension out of that dura, the cranial and spinal dura, as you can, it's a good place to start. Might not fix everything. It's a good place to start. As the spinal dura, so in the spinal dura connects into the cranial dura and has a preference for certain sutures. So we can work on the low back, for example, by working on the sagittal suture. There's points on the sagittal suture that we can release tension within the low back via that dural connection. And I say, 9.5 times out of 10, that's enough. And it's pretty immediate and it works well. There's that, half time out of 10 where, if someone's never had any physical medicine their whole life and they come in, sometimes you need an adjustment at the joint level just to get started, and then you can kind of work through that, and then you can do more of the work on the head. But,
it'd be like acupressure, kind of like, are you just applying pressure in the suture, or?
Kind of. So, yeah, there's in a very specific way. Yeah. So there's sutural work, which is that, right? And then there's also work with the cranial bones themselves. So you might have an externally rotated temporal bone or an occiput that's in flexion. And then we can work, usually those are done with intraoral cranial adjustments. And we're using different points on the cruciate suture, the intermaxillary suture, and the maxillopalatine suture to influence the dynamics within the cranium to move a specific bone the way we want to move it. And that's in either inhalation or exhalation. So we use those to kind of bring it to where we want to bring it. And then we recheck it. I mean, that's the important thing. It's not just like, I think, maybe, I feel, we're testing it and then we retest it. Do we get the result we wanted to get? So that's why I like it, because I think some people are extremely intuitive. I don't feel like I have that gift. Like I need the indicators. It's helpful for me. And yeah, the jaw itself, a lot of times it's more, I'm working on the cranium around the jaw, and I'm working on, if indicated, again, I don't just go in and work on all the pterygoids kind of indiscriminately. It's just, if indicated, we might do an external pterygoid on this side or an internal pterygoid on this side, or kind of balance it out this way. I give them tongue exercises. Sometimes we can recapture the condyle with the tongue. If we can catch it within 6 to 8 months of the disc derangement, we can get the get it to recapture just using tongue and some of the cranial work. If it's past 8 months, sometimes we need some help, but and sometimes you're not going to recapture it if it's past
That's
8
what I
months.
was thinking. The sutures for adults, they're pretty much pretty solid. They're more like
They're solid, but they're not fused. Like the fact that they're fused, that's a misconception. Actually, there's some studies that have confirmed that. Like that would be an atypical presentation. If your sutures are fused, that's a yeah, that's not good. Yeah, and most people's sutures are not fused. They do get more rigid as we age. That's true. But you could still make a big effect on people suturally. And
how long does it take to see that change in the bones, for example, the average?
What bone? What do you mean?
Like when you're repositioning, when they're canted, so you want to align things. What's the average time for you to be able to achieve
for them to get to neutral?
Mm-hmm.
But depends on the individual. I mean, I was like, kids, it's a lot easier. Kids fly through that stuff. I mean, it's easy for them. Kids are. I mean, they're pretty easy. But in adults, well, I think a lot of it too has to do with the time of the condyle can remodel, right? And so if I really like a modified pivot appliance because it kind of lets the jaw pivot and find its happy place, and then over time we're kind of adjusting around the two pivots. And if you decompress that jaw, it's 6 to 8 months, the condyle remodels, right? And it's in a new spot. And so, I'd say 6 to 8 months for most people.
Wow. Very fascinating. It's so different than the typical conventional chiropractic approach. They look at that, where the problem is in the spine subluxation, as much as I have a knowledge on that. But this is where the typical traditional way that they look at the problem. But then for you, look at the more like a macro scale of the entire spine from the head all the way down to the sacrum, where the whole in alignment it is, right?
Yeah, I work on extremities. I mean, it all kind of comes into play. I mean, I think that the traditional chiropractic work I think it's a good tool in the toolbox. I don't find I need to use it as much now as I did before. I mean, I think a lot of those things within the spine, so the main dural attachments that I mentioned before at the top and the bottom. So if I took off my belt right now and I twisted it like this, there'd be a twist that runs through the whole belt. And I mean, you can I could say, Dr. June, try to untwist this belt, but if I keep the ends twisted, it's just going to go back, right? So it's just go back again. So if you don't deal with this, it's gonna be problematic, right? But easier said than done, right? I mean, this is what we're trying to get after is the ends, and then a lot of the stuff in the middle will kind of work its way out, or it'll be easier to treat. You're not having to kind of work on the same spots over and over and over again. But yeah.
And then, so what are the benefits of doing the type of work that you do compared to a chiropractor that does just the maneuvers on the adjustments?
Yeah, so I said, I think, the adjustments work well on certain things, but if you're having to go often to see somebody for the same issue and they're adjusting the same thing every time, then I think maybe like a broader approach is maybe indicated, where you work a little bit more with the neurology. I mean, I said I'm not opposed to doing the adjustments. I just think this way it tends to stick a little faster. You said when you work with the neurology, it's an immediate response, and then it tends to hold longer this way. Like I said, you're kind of getting to more of the root cause. There's always deeper layers, right? As you guys have taught me a lot about that. But to the extent that I do, I'm trying to get to the deeper physical layer to try to affect change in somebody that's gonna stay and as much as nothing holds forever, but what's reasonable, right? So we're always evolving, right?
Absolutely, yes.
Yeah.
So from your approach, the way you're expert on that, what you do, and everything, really realign the whole entire dura, corrections of the spinal process. All the type of clients and patient you see, well, what type of most common symptom, common problems that come to see you in practice?
Most patients I see, I'd say they said at least 3/4 of my practice are patients with cranial-fascial pain, neck pain, TMJ pain, headache, they said jaw pain, these kind of things. That's a lot of who I see. I see some children with cranial-facial development issues. You know, their cranium's not developing, the midface isn't developing, they're developing all these bite problems. And, you know, and for a lot of these patients, I mean, you know, I said I used to do a little bit more of the manual traditional chiropractic work, and then I found that the more I did the cranial work, I didn't have to do as much of that anymore. But then it kind of begs the question, okay, why are people getting these cranial strain patterns? And then that got me into the bite and the jaw. And so I actually work a lot with dentists and orthodontists and other professionals to help balance the bite, and we work together, you know, to try to balance these issues, you know, in a more holistic way. So a lot of people are stuck in these cranial strain patterns. They have all this cranial-facial pain, jaw pain, kids with the cranial-facial underdevelopment. You know, cranial work is helpful. It's a big piece, but to get it to stick, the teeth will kind of set that back again. So we want to set the pattern we want to get them as lined up as we can, then set the bite to that nice pattern. And then rather than, you know, if you're setting the bite and someone's twisted and torqued, you're setting them to that pattern. So you don't want to do that necessarily. So that's a big part of who I see. And then I do see quite a few athletes as well. And then I see some people with low back pain and this kind of stuff, but that's less about, you know, that's just less who finds me. It's more, it's a cranial-facial pain, jaw pain, and cranial-facial development in kids. That's kind of my main demographic, I would say. Yeah.
Very interesting. So I'm really curious exactly. Somebody comes, let's say they have a TMJ. They had having problems with their bite. They are using a night guard, a mouth guard to protect their teeth from because they're clenching or grinding.
Mm-hmm.
And so what will be the maneuver that you will do, the steps that you will follow? What is the science behind that technique that you're using?
Mm-hmm. So with any patient with TMJ, with bites, I mean, there's not like one move, you know. Chiropractors love this. So whenever I teach chiropractors, you know, I go teach a course on TMJ or cranial dental co-management to chiropractors love like a silver bullet, like what's the one adjustment I can do and fix every patient that comes in with jaw pain. I was like, you can't, that's what we're trying to move away from, right? And it's kind of like in dentistry, you know, someone comes in with a TMJ problem, you know, most of the time there's not like a true diagnosis. It's like, let's throw this night guard in the mouth, cross our fingers, right? The chiropractor will adjust your neck, you know, cross their fingers. The PT will give you some stretches, but there's no like diagnosis of the problem. So I think that's the big problem with TMJ issues and craniofacial pain. I mean, I think everyone kind of just throws what they have at it, and there's no diagnosis. So I think that's critical. I mean, I think getting a diagnosis of the problem, you know, is really important. So I know really quickly if this is something I could do by myself or if this is something I'm going to need help with. Now, not everybody wants, you know, I could say, hey, you know, Mrs. Jones, you know, you need full mouth reconstruction. You know, that's going to be the fix to your problem. She might not want that. And then, okay, well, if you don't want that, you know, it's not apples to apples, but maybe this would be an option for you. So I try to kind of meet people where they are in terms of what they need versus what they want out of care. Some people might not have the funds to do all of that, right? A lot of times the night guards, I found the hard upper night guards, a lot of times they're making people worse actually, because there's an intermaxillary suture that runs through the middle of the maxilla. There's not one on the mandible. So a lot of people do better with a lower than an upper. I've talked to people at dental school that teach these days, you know, the upper hard up on that. Why do you guys teach? Like, where does this come from? No, I don't know. That's just the way I was taught it. So there is no. I mean, it's the Wild West with a lot of this stuff. You know, in SOT and AK specifically, they're two of the more research techniques, I would say, by far. I try to put out a few case studies every year it's called the ACC RAC conference. It's the biggest chiropractic research conference. But it's, you know, there is a lot of evidence on things in the body affecting the bite and the condyle position in the jaw. Like that, we have those things. We have, you know, evidence of stomatognathic system, the bite, the jaw, you know, and even cranial torsion from the osteopaths research that's creating a descending pattern. And so we have things that are creating an ascending pattern. even as far away as leg length discrepancy. There were a couple of studies done in Japan. They took a bunch of people with equal leg length, no jaw pain. They gave them a heel lift on one side. So they induced a short leg on one side, had them walk around for a couple of weeks. They started having jaw pain on the side of the short leg, and they were biting harder on the short leg side. So even as far away as the leg length can affect the bite and the condyle position. So, in terms of the evidence base, a lot of the cranial dental co-management stuff is new in terms of there aren't a lot of protocols. That's something we're working on within the SOT community to try to, and some of the dentists I work with, we're trying to develop protocols that at least a starting point for working in a co-management situation. A lot of the dentists and orthodontists don't understand maybe what we do and what we can offer. And some of those studies I mentioned before, and then a lot of the chiropractors, they don't understand the dental, what's a class 1, class 2, class 3 bite, what's a cross bite, disarrangement with recapture, without recapture. They don't know any of those terms, right? Even the craniopaths. So it's a problem, and there has to be kind of a meeting of the minds, and we're working on that.
We need to be working and continue our evolution and continue growing and expanding our awareness. And that's something that we encourage people to do. Just to become aware of their condition, their situation, learn from that process, and then just they can achieve well-being. So which one has been one of your, like an impactful case, something that is just comes to mind that is like, I had really great success with this patient and it was just really great success?
I had a little girl who came in, she's 8 or 9 years old. She was having bedwetting issues, behavior problems. She was having some physical symptoms, some headache that weren't going away. These kind of things. She had her main issues were actually in her mouth, right? I mean, she had sleep disordered breathing, it's like if you or I were walking around and we were only getting 1 hour sleep a night, we wouldn't be very pleasant people to be around. And that's a lot of these kids. You could see it in their face. Their open mouth posture. They have bags under their eyes. A lot of those kids are labeled as ADHD, ADD, and they're just not getting sleep. And it's no different than how we would act if we were like that. It's just very few people it's not on people's radar to look for that. And I think that's one of my soapbox issues. I mean, I think that's a huge thing. You can, as you know, right, it's really easy to work on these kids to fix that stuff when they're kids, rather than waiting. So this girl, we kind of identified that. I treated her a few times, and then I had her, essentially we just tried to get as much tension out of that cranial dura as we can. We worked on myofunctional issues, which, tongue, all that stuff for her went back. A lot of people goes back to tongue. So she, was kind of underdeveloped in her mid-face, had a lot of bite problems, but a lot of it went back to the tongue. So we were kind of working on some of those things. And then I had her in like some tongue training appliance to help kind of train her tongue to get up. And it was just pretty remarkable, within a few months, she was just stopped bedwetting, her behavior was better, grades were going up. I mean, it was very fulfilling to see. And then, we had some pictures later on for this girl, just 6-8 months later, but all her teeth were straightened out, her palate had widened, her mid-face had developed, and it wasn't anything I did. It was just, we just set up her body to do that itself, right? So when her lips are together when she's sleeping, her tongue's up at the roof of the mouth, she's breathing through her nose. We work through the cranial tension that she had, some of the other issues in the body, and it's just her body could relax, and then the tongue starts driving all that growth, and the force of the tongue and the lips start straightening out the teeth. Her swallow was functional. It was a big change for her in a really quick time. And it wasn't a lot that I did really. You're just with kids, you're just kind of riding the ship, making sure they don't veer off into the side. You're just, no, going back over here. And she's been really good. She still is a little bit mid-face deficient, so she's still going to have to probably get her maxilla kind of drawn forward a little bit with some remodeling appliances. But I mean, she's night and day, but I mean, she's starting 90% ahead of where she was before. So it's going to be a really easy case now for the other practitioner to deal with, because she's already most of the way there. So that was really fulfilling to me.
That is incredible. That is incredible.
Isn't it?
Are just amazing, because everything is still kind of growing and expanding and adjusting. So minor changes and just the right guidance can improve and even save money for the parents, because they might have to spend like 2 sessions of orthodontic treatment and then struggling with the kid. And then maybe what you just said was amazing, because a lot of these kids are being labeled as deficiencies like hyperactivity, and it is just a lack of sleep. They're not having the quality of sleep that they need. It's just beautiful, and I would love people to just know more about that and just being that simple things. And a lot of people don't know what's the right position of their tongue to breathe, swallow,
right.
where the tongue needs to be, and it's so crucial. So if you can just give us a little bit of things that, like, what is the right position and how people need to be functioning, basically.
Sure, man. Just to kind of piggyback off the point you just made, one thing that I wasn't aware of, I mean, we're looking at airway, we're looking at cranial tension, we're looking at some of these other symptoms, but there's been some studies on sleep disordered breathing in children and bullying. So a lot of those kids, they just kind of look, some of them are a little more overweight, they get in trouble, they're not as sharp, and they're kind of, the facial changes that develop as a result of that, they're a lot more likely to get bullied in school, which is, mentally, if somebody tells a child, oh, we can't work, wait until this kid's 15 and then work on this kid, how much damage has been done just in terms of sleep disorder breathing, and your neurology of how important sleep is, but also the 15 years of bullying versus maybe 5 years of bullying, right? I mean, that's a significant mental difference, right, for that child. I mean, that's a big deal. So so there's a lot of pieces of that. But yeah, so when you're a baby, a baby doesn't actually suck on the nipple. It compresses the nipple onto the roof of the mouth with the tongue. So that's why a lot of children with feeding issues, it's really important to connect with the lactation consultant, because they can kind of go through and see, is it just a matter of your kind of the logistics of learning how to do all those things, or is there a tongue tie or a lip tie, or is there's some physical restriction that's causing the baby to not be able to feed correctly? So a good lactation consultant and some pediatricians will be able to kind of notice those things, but ultimately the tongue, that when you're a baby, the tongue compressing the nipple on the roof of the mouth, it strengthens the tongue and teaches it to get to the roof of the mouth. And when you're not speaking or eating, your tongue should be up on the roof of the mouth. Your whole tongue should be up on the roof of the mouth. Your lips should be together. You should be breathing through your nose. When you swallow, your tongue, instead of going down and forward, which is a dysfunctional swallow or a reverse swallow, your tongue should go up and back. And so that's a normal pattern. When that does not happen, if they're because of tongue tie or whatever reason, and the tongue is down, the face is going to grow long, and then the jaw is going to usually be jammed back. The tongue attaches into the jaw and into the base of the skull. So when the tongue is up, it pulls the jaw down and forward. So a lot of these kids that are kind of like this and their jaw is sunken back, a lot of those kids that have tongue dysfunction problems. In their mouth breathing. So the more you mouth breathe, the more dental issues you have in terms of crowding, and in terms of cavities, a lot of issues. You're not breathing properly. You're not getting as good nitric oxide comes from nasal breathing. But cranially, getting the tongue up on the roof of the mouth as a baby is the pressure of the tongue on the top of the maxilla, the midface, is what expands the whole midface laterally and forward. And that makes room for your maxillary sinuses, but it also makes room for your dental arch. So if a child comes in and they have a lot of crowding, I know that they're underdeveloped in their maxilla. And then one of the first things I look at is the tongue. You know, if there's a physical tongue restriction there that's keeping them from getting there, then maybe we need to deal with that. If it's not too bad, then maybe we can get around that for the moment and just work on tongue placement, and maybe it doesn't actually need to be surgically fixed. Maybe we can do some other things with it, with the cranial development or the tongue, and try to get it functioning as it should. And then, you know, I said we're lucky in this area. There's a lot of good people to work with. If we need bigger guns, those people are here too. So it's nice to have them as well.
Have you noticed like certain things are attached to emotion, certain conditions or certain problems that the patients come to see you? They have a connection with some emotional aspect?
Yeah, I mean, we all have that, right? I mean, to some degree, right? We all have that stuff. And I said it, in AK specifically, you know, that was the biggest thing for me in going through the applied kinesiology training and the certification, is that emphasis on the physical, but also the chemical and the mental emotional. So 10% of people, they'll have like a major neurologic response, which frightened me at first, but now it's like it's never been a bad thing, but there'll be like a tremor that they'll have, or like a shaking. Some people, it's almost like a full-on seizure, and it's a big release for them. It's not uncommon for people to cry or they'll just start laughing kind of randomly. I mean, it's just, some people are just stuck in this sympathetic, and once you can get them to kind of come out of that, it's just, it affects people different ways. Yeah.
I mean, this is where, you know, I think you brought up the greater level of awareness, right? You mentioned about that, the connection between the emotions and the chemical, the physical, that triad. That's the brilliant. They said that we need to have that, because you brought awareness, and then EMDR practitioner need to be aware that that's not that, but there's a structural components, the chemical components, right? So we all need to work on that, increasing the level of awareness, so then we can work together. So it's not say, hey, come see me, I can kind of, you know, cure you. It's not that, you know, it's not that simple, right?
Especially around here. I mean, why would you want that burden? I mean, gosh, I feel like I have enough to do. I mean, I can't. I mean, you know, if you're practicing in the middle of nowhere, right? Maybe you have to do that. But around here, why would you want to? I mean, there's so many good people here to work with, and I said I have enough to do just staying in my little avenue here. I don't, you know. Yeah. I think we're lucky here. I really feel that way. As practitioners, we're lucky to have so many good people here.
Yes. Well, thank you, because that's what we are passionate about, bringing this, we are closing the gap between the integration, you know, between the ancient wisdom, all those information, the knowledge available, but yet there's a modern science, you know, science really proving a lot of things. So how can I, you know, putting all the pieces together? This is where you're joining us, you know, they're helping us to bring awareness, and then we can have another doctors and healers, practitioner, bring it onto the table, that we all have that level of awareness that, you know, humans are very unique and very intricate in a way. You know?
Yeah, I mean, the more you learn about the body, the more you realize we had no idea. I mean, we're just getting started, right? Yeah,
that's so true. Thank you so much. Thank you for
Thanks so much,
guys, and for all that information.
Oh, thank you guys for having me. This was fun. Thank you.